Good afternoon, and today I have a pleasure of interviewing Dr. Jorman Ramirez. He's joining us from Aurora, Ontario, Canada. Good afternoon, Dr. Ramirez.
Hello, Maria. How are you?
And today we're gonna talk to Dr. Jorman Ramirez, pediatric dentist and orthodontist in PhD in oral biology, about real drivers of craniofacial growth in children. And we explore the clinical role of nasal breathing, early intervention, how it shaped the airway, and how very often traditional orthodontics miss that root cause. And also we're going to talk about non-custom expansion, myofunctional therapy, custom expansion, how it's all play the role and can be incorporated in treatment and why. And we're going to talk a lot about nasal breathing and how to breathe right. But now I'm going to introduce you Dr. Jorman Ramirez. He's going to be teaching on a conference what happened in Long Island, organized by Dr. Lambert, Steve Lambert, and the board on kind of collaboration between dentistry, medicine, and myofunctional therapy and other type of therapy for the body. So trying to look holistically on the whole body, and he's going to teach on that topic, and I'm so looking forward to listen to his presentation and learn from him. And we're going to do it in kind of a short form now, because Dr. Ramirez has a really, a lot of knowledge. He got his dental degree from Columbia, then pediatric dentistry diploma from Mexico, and then Master of Dental Science and PhD in oral biology from Australia, and then craniofacial pain residency in Tufts, just like me. I did that residency program as well. And now he's going to have his course in a couple of weeks. He's going to talk a little bit about that in May in Toronto for dentists who want to learn a lot about myofunctional orthodontics and how it has to be done. So please, and he's author of the book, Pediatric Airway Focus Myofunctional Orthodontics. So that's a great book to read as well, in addition to the course, in addition to the PANNY conference. So please share with us, Dr. Ramirez, how from pediatric dentist, what drove you into that field, what you start seeing a little bit deeper?
Yeah, it has been a journey since I finished my dental degree in Colombia, my home country. And then I got the training in pediatric dentistry. And when I was treating kids, I was seeing a lot of bite problems, a lot of malocclusions in these children. And I became interested in that area, how to correct those problems at an early age and not wait to what people know as the age of brain. Yes, I had a very long journey on this pathway, because when I finished my dental degree and I became interested in working with children, I got my training in Mexico to do that, and I got a lot of patients that they have bite problems at a very early age, even in baby teeth, right? And I started interested in how to sort out that problem, because the parents didn't want to wait until the age of braces later. And so I started working on that, and I found very interesting techniques. I got some trainings in Brazil on how to work with functional appliances and functional techniques. And then I decided to move to Australia to understand better how the mouth work, because we are a specialist of the mouth as a dentist. So I wanted to understand how the mouth work, and when I was putting something in the mouth, how this was going to react. So that's why I decided to understand better the oral biology, the biology of the mouth. And when I was treating kids, I was seeing that these kids that I was treating because a bite problem, a malocclusion, these kids had breathing issues and sleep issues. So that's when I decided to do the master in craniofacial pain and sleep disorders. But I wanted to do that to understand the problem and then to bring that to children, because everything is focused in adults, but nobody was focusing in children at that time. So that's why, for example, you were mentioning PANNY that is going to happen the first weekend of May. We are going to discuss that. We are going to discuss how we can correlate those bite problems that we are seeing in the mouth and the sleep issues that the child may have and the breathing issues that the child may have, right? And we are going to discuss, for example, how the structure of the mouth is limiting the function and how the function of the mouth is limiting the structure, is affecting the structure. So normally when we have a problem like that in kids, and we are going to discuss about this in PANNY, how we need to correct both sides at the same time, because there is a lot of confusion. Do I take the child to a myofunctional therapist or do I take the child to a dentist? No, the child has to be seen by both at the same time and to be coordinated by the dentist correcting the structural problems and the myofunctional therapist correcting the functional problems. And in that way, we can achieve a result at an early age, because many parents ask me why we can start early and not to wait for the age of braces. And I explain to them, your child is growing, right? Your child is growing at this moment. So whenever we start early, we are doing that. We are guiding the growth and development of the mouth and the face. And if we think a little bit on that, indirectly, we are not physicians, we are dentists, but indirectly, we are giving the child a better way, a better structure to the airway, because the palate, the upper jaw, is the floor, the roof of the mouth, but at the same time is the floor of the nose. And whatever we do in the palate is going to affect the structure of the nose as well. And when we have the upper jaw backward, for example, when the patient, what people knows like an underbite, that the patient is bringing the jaw forward, could be because the upper jaw is backward. And if the upper jaw is backward, it may affect the passage of the air at the back, because the air is flowing through the nose, but going behind the mouth to get to the lungs. So that may blocking the passage of the air at the back. So we need to bring that maxilla forward. And if we bring the maxilla forward at an early age, we can prevent a surgery later, right? Or on the other side, if we have the lower jaw backward, the tongue has to move backward. And if the tongue is pushing backward, it's blocking the passage of the air as well at the back. So if we bring the mandible forward at an early age and the mandible is growing, we can get a better result and to prevent a surgery later. And the other thing is, if we develop the jaws and we create a good space for all the teeth to come, we are going to prevent that later. To do an orthodontics, we need to extract teeth, permanent teeth, right? So it is worthy, even though the patient may need a little alignment later and to put the teeth in a better position to look better. But we are giving a space for all the teeth to come into the mouth because the child is growing. And we are going to give a better airway to the patient because the structure of the mouth is supporting a better airway, right? So that's why it's worthy to create all this growth and development in a child that is growing and not waiting until most of the growing of the craniofacial structure and the face has happened to start correcting the problem. We need to be aware that about 6 to 7 years old, every child has completed about 80 to 90% of the structure of the face. So if I can treat earlier, if I can treat a child in baby teeth, in primary dentition, or early in mixed dentition, when the new teeth are coming into the mouth, the child still has a lot of growth potential, and we can develop better all those structures and prevent a lot of problems.
That's a beautiful explanation, and I'm so, like it sounds like a music to my ear, and I reflect it in my book. But at the same time, as adults or as a parents, we also don't want to start so early to not to medicalize the childhood. I had my orthodontic treatment starting from age 4, and I was not happy about that at all. It's a very I know that like I'm teaching the same factor, but it's it's a balance of two things, like medicalizing childhood and creating better future. That's equally important. So I'm going to ask you that question on that topic. You talk a lot about gaggers. That's the dental nightmare. If people come to the dentist, they know they gag in a dental chair. No one explained to them. They said, I'm just like that. I'm just very sensitive. But your philosophy, how you address the gagging, and a lot of kids actually do that.
Yes,
Yeah.
one of the things that we need to think, what is happening when you gag? What is happening to a gagger? The gagger is protecting the airway, right? The gagger is a mouth breather. So if the patient is trying to breathe through the mouth and we are trying to put something into the mouth, the patient is immediately going to protect the airway and is going to react because the patient is not able to breathe at that moment, right? We are blocking the patient is used to bring the air through the mouth more than through the nose. So in those cases, that's why we cannot generalize that we have to put this kind of appliance or we need to do this kind of treatment for every patient, because we need to analyze every case very careful how to start with a patient. For example, if we have a severe gagger, a severe mouth breather, we need to start correcting that functional problem first. We need to teach the patient to breathe through the nose. Once the patient is able to breathe through the nose, and there are different techniques, and there are very well myofunctional therapists trained to do that. And once the patient learns how to breathe through the nose, then we can deliver an appliance. Because what happens if we see a problem in the mouth that obviously is associated with the mouth breathing and some sleep issues, and we try to put an appliance in the mouth, that appliances in general are designed to block the passage of the air through the mouth. And the patient is going to be feeling uncomfortable and the patient is not going to use that. So that's why we have to evaluate the patient and to see, all right, this patient should start with appliance only, this patient should start with myofunctional therapy only, or we should start at the same time in coordination. That's why it's important that the dentist and the myofunctional therapists are working together and in coordination. So any step to correct the structural problem is at the same time followed by the myofunctional therapies to correct the functional problem. And in that way, we can correct all the problems, the structural and functional, at the same time. But it's important that the people understand that a gagger is a mouth breather, and we need to
Yeah.
work on that, right? That's very, very important.
That's very important. And, yes, we focus now on kids, but as kids become adults and they are very scared to go to the dentist for that exact reason. They don't want to be uncomfortable and embarrassed and create, discomfort for people around them. And then they just don't do it. So that's also,
Yeah.
it's a very sad and big issue for a lot of people. And dental phobia really rooted in that gagging.
And it's important that the people understand that that adult that is with obstructive sleep apnea and has to sleep with a CPAP machine, that problem didn't start yesterday. That problem started a long time ago, and it's a full spectrum. So when we see a child that is mouth breather, that a child that is not sleeping well, that is restless, a child that is waking up during the night, that is the initial steps of becoming an obstructive sleep apnea as an adult. So if we start correcting that in a child, we are also preventing that that child become an adult with obstructive sleep apnea and probably sleeping with a machine every night, right? So that's another thing that is very important to remark to the parents. Why is important to start early? Because if the child is a mouth breather, a gagger, an overbreather, probably the child is not with the mouth open all the time, but is breathing too fast. Is that child that you are with the child and you can hear a heavy breathing all the time, even though that the child has the mouth closed. Those are the first red flags that is telling us the child has a problem. And that could be associated with a structural problem in the mouth. So we dentists can correct that structural problem together with the myofunctional therapist, correcting the functional problem, and then we are going to give a better functional oral functions to the child and a better structure for the airway.
Yeah, no, it's all, yes, it's all sounds wonderful, but can you share with our audience regarding the breathing? I know you're big proponent of changing the breathing pattern. So, simple things, people can check how many breaths they do per minute. What do you find, healthy? Tell me, Dr. Ramirez, the simple test what parents can do at home to check the child's breathing during the day or during the night. How many times per minute should child breathe?
Yes, so basically we are breathing. The ideal is to breathe around 10 times per minute, right? That's the ideal. 10 times per minute, exactly. And we are seeing children today that they are breathing 20, 30 times per minute. That is over breathing. And that is causing problems as if they were breathing through the mouth. And many times I am with the parents and they say, no, my child is with the mouth closed most of the time. So and I ask, when your child is watching TV is with the mouth open? Oh yes. When your child is paying attention to you is with the mouth open? Yes. So it is not necessary. People has the idea that a mouth breather has to have the mouth open all the time. No. If I maintain my mouth open, the tongue has to descend to permit the passage of the air, and immediately I start mouth breathing. So 30 seconds, 1 minute, 2 minutes with the mouth open is already a mouth breather. It's a mixed breather. It's breathing through the nose and to the mouth, but it's already a mouth breather. And or the over breathing. So what happened with the mouth breathing and the over breathing is that we are removing too much a gas that is called CO2. We are removing too much of that from our body. And what is happening? We are using only the chest part of our lungs. So we cannot take a lot of oxygen into our body. So basically, we are not bringing oxygen to ourselves. And that's what is happening. And that is connected to many problems in our body, many diseases. And today we have evidence, scientific evidence showing that a lack of oxygen is causing a lot of problem in the health system. And a lack of oxygen is because mouth breathing or over breathing. So that's why it's important that the parents start identifying that. And for example, parents say, no, my child is sleeping well. And I ask, but your child moves a lot during the night. Oh, yes, it's a total mess in the morning. The bed is a total. That is a child that is restless. So that child probably is with the mouth closed, but every time that the child is feeling need to breathe, is moving around and is opening the mouth, and then the mouth is closed. So I normally recommend the parents start checking at night how your child is sleeping. Start checking when your child is not concentrated in doing a specific task, but for example, totally unconscious watching TV, or if your child is falling asleep when you are riding in the car. Those are signs that the child is not sleeping well and is not breathing well. So it's important that the parents start evaluating that, and then to bring the child to be evaluated and to work in making a full nasal breather of that child. And that is going to help for the whole health because the body is receiving a good quality of oxygen in the whole body and in every cell of the body.
Do you, as a last question, do you have any special tricks for parents, what you recommend, like games, to improve the nasal breathing for a child and not to be over breather, like specific practical games? I apologize, we have some connection problems with Dr. Ramirez, but you can read his book, and he's going to be teaching on PANNY and on his mini residency. Thank you very much for your attention, and we always appreciate our audience.